Thank you, Molly, for that generous introduction. Good afternoon, everyone. Before I start, I too would like to pay my respects to the traditional owners of the land that we're meeting on today, and pay my respect to their elders past, present and future, and those that are joining from other communities today, either here or dialing in. I also wanted to congratulate the VCCC for such a dynamic and innovative educational initiative such as the Lunch Live. I know that we've been listening in keenly from Cancer Council, and I certainly feel very privileged and excited to be part of the program. I know that when we were listening to Stephen Duckett, I think Grant mentioned that he could see 70 people online, and I knew that one of those people online actually had about 12 other people with them, because that was my group at Cancer Council. So a shout out to my team at Cancer Council, but also to say that it's wonderful that work is being disseminated and accessible beyond these walls. So I welcome that. Today I'm here to talk about two studies that were undertaken as part of a scholarly selective project last year. For those of you who aren't aware, it's another wonderful initiative from within the precinct, which is the University of Melbourne medical students in their final year electing to take on a research project. So the research project was undertaken by a wonderful, dedicated student, now a junior doctor at Goulburn Valley Health, Panthera Samapivapan, who was supervised by myself, who has a background in allied health supportive care research, a dietitian by training, and by Alison Hodge, also at Cancer Council, who is a nutritional epidemiologist. So between the three of us, the work that was conducted was twofold, and that's why I'm here to talk about today. One of them was a systematic review looking at the extent to which alcohol consumption is associated with the recurrence of cancer. We've got really good evidence about causation or association between first cancers developing for alcohol and cancers such as lung and breast, bowel, mouth, stomach, esophageal, and others. But really it was looking at, in our survivorship population, how much alcohol is a problem. And I guess for me, these kinds of questions always stem from a professional gap or frustration or question that challenges clinicians, and that's been where I've come from with a clinical oncology and dietetics background. And it's fair to say that this work would not have got done if Panthera didn't come on board. And I know that others in the room will have been lucky enough to host and supervise scholarly selective students. And I'll come back to those at the end. I want to make another point about that. So the systematic review will be presented today, as well as a qualitative interview study where Panthera engaged clinicians working in the area to start to explore how do you have conversations with your patients about alcohol, what helps you do that, what are challenges to that. And some of this work was presented by Panthera at COSA last year. It was also presented in a form at Cancer Council's Behavioural and Research Cancer Conference in May this year. And it was at that time when I think Michelle, who invited me to be here today, really heard about this work through the media storm that happened around it. So I want to give you a little bit of insight into that today. And if you missed the news in May, you wouldn't have heard about this, but I think it was quite a big story, and I want to talk about how that played out. It was in the news so much that my mother rang my mobile phone, and she never rings my mobile phone. And she rang my mobile phone and said, "My friend rang and told me you were on TV." And I was nowhere at TV time. And I said, "Oh, what was I saying?" And she said, "Oh, well, you were talking about alcohol and breast cancer. And my friend said that it was your research, but I told her it wouldn't have been your research. You would have just been explaining what it means for people." So I'm glad my mother has such good faith in my research ability. I'm actually still doing some. So anyway, we'll get to that. But look, at the conference, which was in Melbourne, I did present on the work. The systematic review had just been published, and the qualitative interview work was being written up. And Panthera was on placement at the time, so couldn't come and do that. And we made a decision at Cancer Council to put this out as a media release, this work, mainly as a message of public awareness that there actually is a link between alcohol and cancer. I know I'm preaching to the converted in this room, but actually that's not a link that everyone makes, and it's certainly not a link that the general public or patients necessarily make. And it was also to promote the conference. But on the afternoon that I presented, my CEO, Todd Harper, called me over and said, have you seen this media release that's circulating? And I hadn't seen it, and I obviously needed to confirm it. And the key sentence in there was that associations between breast cancer recurrence and as little as 6 grams of alcohol a day have been found. And as a dietitian, it's very important that I quantify that as a portion size. So I had explained in the media release that this equates to 3 tablespoons of wine a day. And Todd said, this story is going to be huge tomorrow, and I thought, it really won't be. It's not that exciting. How do you know? I said, he's an ex-journalist, and he said, I've just got a feeling about it. And he said, I suggest that you go home, set your alarm for 5 o'clock and wait for the phone to start ringing. So I did. And this is what happened. He was right. It was really annoying. This story was massive. It was in 3 newspapers, including The Age, the front page of the Herald Sun. It was on 6 radio stations. I think I did my first interview at 10 to 7 in the morning. It was on 4 news programs, 7, 9 and 10 that night, and The Project. So it's fair to say there was some public interest in it. And I'll get back to some of that controversy, I think, but really you can see the headlines there. I think I was surprised that this was new news, that people didn't know that there was a link between cancer and alcohol. And although this was specific and it was about breast cancer and breast cancer recurrence, and I'll talk about how much evidence there actually was to say that, in the questions that I was getting in the media, it was really back to basics. So how do we know that alcohol contributes to cancer? And we know that a third of cancers in Australia, up to a third of cancers, can be prevented by changes in lifestyle, alcohol consumption being one of those lifestyle, those modifiable factors. So that's a little bit of the background to how I got here, because I don't think Michelle read the research. I think she saw the news. But either way, it's a pleasure to be here. So as I said, we've got convincing evidence of the link between alcohol consumption and first breast cancer, and the World Cancer Research Foundation have stated that there's a 10% increase in risk of all age breast cancers with every 10 grams of ethanol consumed per day. That's 1 standard drink, we'll go on to see. And the LACE study, some of you in the room or listening in will be aware of, the Life After Cancer Epidemiology study that showed this in 2010. So that study itself was showing that amounts far less than what we currently say is okay to drink, 2 standard drinks a day, was associated with an increased risk. And I've heard oncologists in this institution talking about that in 2012 and being guided in the conversations they have with their patients around that particular study. So this wasn't particularly new, but what it did is looked at that study and any other studies that also investigated recurrence risk and pulled them and made some statements about it. And I'll go into the results in a minute. There's also evidence, and those of you in the room who have had to have conversations about alcohol with patients or feel that you've got a professional responsibility to do that, will know that that's not always straightforward, and it's difficult to know what to say and how consistent to be. The NHMRC guidelines are our public health guidelines around alcohol consumption at the moment. They're being reviewed right now, and they're the Australian guidelines for health risks associated with drinking alcohol. I'll just show you what they state. The current population is for a maximum of 2 standard drinks a day, and we know that the World Health Organization says in your country just follow the public health recommendations that are for cancer prevention. That's for everyone. But there's this sense that there might be an increased risk for people who have had a cancer diagnosis in the past. So this is just one portion of a diagram that gives a sense of what this standard drink is. It's hard to commit to memory, and it's really variable. So if it's a beer and you're having one standard drink, it's 0.8 of a can of a light beer, one can of mid beer, or 1.4. Sorry, the other way around. A can of beer is one standard drink. If it's mid beer, if it's a regular strength beer, then you're actually getting more than one standard drink in a can. It's 1.4. 100 mils of wine. I'm not sure who knows how much gets poured into a glass, but I can guarantee that if you're drinking wine, you're drinking more than 100 mils. In the top restaurants, when you think, $17 for that very small portion, that's 150 mils. So one standard drink can get consumed very quickly. And just for context, and to add to the confusion, what I've listed there is what the guidelines are in other countries. And obviously we're reading literature for various audiences that are based on different standards. So in the UK, it's a maximum of 14 units per week. So if we're thinking about standard drinks, that's on a lower quantity. 8 grams of alcohol is one standard drink, and they're saying up to 2 of those a day. USA, portion sizes large, everything seems a bit upscaled. So they're saying a maximum of 1 standard drink per day, but that's a bigger drink. It contains 14 grams of alcohol rather than 10. So that's the context. The aim of this particular work was to explore the extent to which alcohol consumption contributes to breast cancer recurrence, and the way that this is discussed between clinicians and patients. And there had been a recent UK study by Jane Wardle's group that showed clinicians in the oncology setting really weren't well versed in lifestyle advice and knowing exactly what the recommendations were around exercise and smoking and drinking and things like that. So there hadn't been a study like this in Australia, so we went on and did the systematic review, but also did the clinician interview study. Both of them are published, and Panthera is the first author on both of those pieces of work. And so not only am I here today and she's presented around the country, and we're using this to disseminate it and create a discussion or debate around what we should be talking to our patients about from this work. But she's also a graduate doctor, and she's got 2 first authored papers as part of that work, which is really exciting and speaks of the achievement that she was able to go on to achieve. So we wanted to talk to clinicians about, and it wasn't to scrutinise, it was to explore current practice. So how aware are you of the public health recommendations? Do you use them in your work? Do you use other recommendations instead? What kind of, how did conversations start? Why do they not start? And then factors that influence how those occur. So I'll talk first about the systematic review, and 16 studies were included, 11 which were assessing a breast cancer coming back, and 5 which looked at a second primary. And we didn't start out with that intention. We started out just looking at cancers that came back, but when we looked into the literature, and the clinicians here will know, it can actually be really quite difficult to work out whether it's a second primary or a recurrence of cancer. And certainly in the literature that was not well defined all the time. And so the analysis was separated, but actually we included papers that looked at both. And I'm not here today to be adamant that 6 grams a day association is what we should be telling all patients. I'm here to be really open about how much weight we should put to a finding like that, and really start some discussion around what conversations do we have, how do we give patient consistent messages, and how's it done here, how's it done in other places, whose job is it? This paper gave us some clues toward that, but it's reasonable to say that there was lots of methodological inconsistencies. So really the studies that were included in the review were often prospective or retrospective cohort studies where the researchers examined how much people drank either before their diagnosis or after their diagnosis, or sometimes both, and then followed them through for a certain amount of time, in some cases up to 15 years, to look at whether cancer recurrence occurred, and then we're able to stratify by the different level categories of alcohol intake. The problem with that is that how alcohol is quantified differed between the studies. So sometimes it was based on standard drinks. You can see in different countries they're different amounts. Sometimes it was on self-assessment about whether you describe yourself as a heavy or a light drinker. I was on a number of drinking years sometimes, so time from first alcohol. And so it was difficult for us to compare like for like across the papers, and we're quite open about that. Also how recurrence was defined. Like I said, sometimes the papers included contralateral events as a recurrence, sometimes not. One paper didn't specify, for example. And there's some evidence as well, and you'll see that in terms of how much evidence is there, that what we found from the papers that roughly half of the papers had a modest but significant association between alcohol consumption at a higher level compared to a lower level and the cancer coming back. And that was really the gist of the media storm, I suppose, and like I said, I'll talk a little bit more about that. This is a forest plot for the non-statisticians in the room. I'm going to try my best at describing this in really simple terms and what it shows. But this is really the question about, well, how much of a problem is that 6 grams a day in terms of inferring a greater risk? And what the graph shows is that the shapes there are the relative risk of developing a second cancer, the risk between those who consume higher quantities of alcohol compared to those who are drinking lower amounts. And if the relative risk is 1, which is shown by the vertical line, black line there, then it means that there's no difference in risk between those who drink more compared to those that drink less. If it's greater than 1, then there is a greater risk with drinking more alcohol than less. And if it's less than 1, then your chances of developing second cancer go down as you drink more, which isn't what we'd expect, and it's certainly not what we're seeing. But again, those who aren't familiar with seeing data in this way, those horizontal lines, they're confidence intervals, and what they show is that that shape can sit anywhere along that line. We're actually not confident where it sits. So the shorter the bars and the further the shape is to the right, the greater we would say that the risk is. Part of the limitations with this study is that some of the papers in it didn't set out to test this. They just happened to have alcohol data as part of dietary intake data when they were looking at factors which might be attributed or associated with the chance of a cancer coming back. And so we don't have a lot of confidence that that's a true association. However, if we look at mainly the Kwan studies, who's the author of the LACE study, and what you see on this graph is it broken down into subcategories. So looking at risk stratified by menopausal status, by BMI status, and then by type of breast cancer. You can see that at worst, when we're most confident, the relative risk of the cancer coming back is 1.35. And what that means is that someone who drinks at a higher level, and in this case it was greater than 6 grams a day, or up to, sorry, at 6 grams a day or more, is 35% more likely to have a cancer recurrence than someone who does not drink or drinks less than that amount. When you compare that to something like smoking, the relative risk of smokers getting a lung cancer compared to never smokers getting a lung cancer, that same risk is 23. So someone is about 23 times more likely to get lung cancer. And in this case, it's only a third more likely. So I think I put that out there because no one knows whether that means we should be telling people to only drink 6 grams a day, that the association or the cause isn't crystal clear. But there's some emerging evidence, and certainly we need more to be more confident in that explanation. In terms of numbers, and again for context, roughly 18,000 Australians will get diagnosed with breast cancer this year. And we don't routinely record recurrence rates on our cancer registries. But Kemp Casey and their group in 2016 modelled that there's a 3.3% rate of cancer recurrence in the breast cancer population. So that equates to about 600 Australians a year. And we can't say that if those 600 didn't drink, a third of them wouldn't get their breast cancer coming back. But we do know that within that group there'll be some people drinking more than others, and that is a modifiable lifestyle factor. So all those limitations don't come out in the media story because it's a long story and it's pretty uninteresting to the average Herald Sun reader. And so the media jumped on that idea of, oh my God, 3 tablespoons of wine and my breast cancer is going to come back. And it's a fine line to play because you actually don't know exactly how the story is going to be played back the next day and what reaction people are going to have. So it's fair to say that the drinks industry reacted to this and cancer survivors reacted to this. And not surprisingly, they wanted to know whether that meant that they should be doing something different. And probably more concerning is that they wanted to know whether they'd caused their cancer to come back. And so we were very committed to getting to those people and explaining that this is population level, you know, that interpretation that we have public health recommendations and this is what they are. It's very difficult to know whether a single person who did not drink would not have the same outcome. So again, that's just putting it in a bit of context for you. So I'll move on to talk about the qualitative interview studies, and we've used this methodology with topics of clinical relevance before, again in this institution around taste function and how that's discussed between clinicians and patients, again not to scrutinise but just to ask how it works, because that often helps to uncover the challenges that clinicians have. And so we recruited through Cancer Council's Victorian Cancer Clinicians Network, which is a over 700 strong group of, it's a community of practice, if you like, clinicians that come together to advocate for and debate different issues of clinical relevance and policy relevance. And then there was a bit of a snowballing effect. So if someone accepted an interview, we said, do you know someone else that would like to do that? We approached 57 clinicians, so 27 represents about a 47% response rate, which was very generous when people have very busy clinical roles. We approached from the breast cancer subgroup of the clinical network, oncologists and dietitians and breast cancer nurses. And so the group is made up of 8 dietitians, 10 oncologists, 3 of whom were rad-oncs and 7 were medical oncologists, and the rest were nurses. And we wanted to work out or talk to them about their awareness of the current guidelines, what their current practice is, like I said, any challenges they have, and then what they could use to help improve those discussions. And this was the second paper. So there were some open and some closed questions. And this is the closed questions, if you like. We wanted to know who knew what those public health recommendations were. About half of them were able to accurately recall the NHMRC guidelines, the up to 2 standard drinks a day. About a third knew a recommendation, but it wasn't necessarily the right one. And 3 weren't able to recall any guideline details at all. And again, it's debatable about whether that should be top of mind for someone. But if clinicians aren't clear on what those guidelines are, how do they explain those to the patients? There were other questions, and I might just tell you a few of what they were that we asked specifically in the interviews. So we asked if they were familiar with guidelines for recommendations regarding alcohol intake, and do they use those guidelines? Do they refer to them in their interactions with patients? Do they differ for a patient with breast cancer compared to a different kind of patient? How would you describe what a standard drink is to a patient? That was a really tricky one. And how often do you find that patients are raising this in consultations with you? What circumstances make it challenging for you to give advice on alcohol intake? What tools do you use? Are there props and things? What do you find most effective? And then if there's anything you could have to make it easier for you to discuss modifiable lifestyle factors with your patients, what would it be? And we asked specifically who the clinicians think the role of that lifestyle advice falls under, so which professional group. I think one person who obviously knew the guidelines very well could describe all the standard drinks, what one is, 100 mils of wine, 30 mils of spirit, 285 mils of a light beer, the whole gamut. So 1 out of 27 is what we were looking at. And it's fair to say people were saying, well, they're not very practical guidelines. I would never describe it in that way to a patient. I use other ways to do that. And that was a discussion that I'd been having with the medical oncologist here in 2012, who was saying, the LACE study is saying it's 3 or 4 standard drinks a day, but our public health recommendations for everyone are saying up to 2 is okay. So in terms of the qualitative data and what kind of factors were coming up, there were some that were patient factors that determined how a conversation ensued, and there were others that were clinician-based. So the patients generally were a lack of awareness. So the clinicians were saying, well, the patients don't necessarily bring this up, or they don't often bring it up. And when they do bring it up, it's not about necessarily about long-term health. It's about interactions, and then some about what that means for me as a person. I'll go on to tell you a little bit more about this, but the clinicians said the standard drink framework was unhelpful. They don't use that. It doesn't have clinical utility. Again, touching on the earlier conversation that the current guidelines are too generous. That was their words. And that some patient characteristics fed into whether they did initiate that conversation or not. In terms of the challenges and opportunity, always timing and workload. You know, it's a busy consultation. You know, there's survivorship and other treatment elements at stake. The sense that it's everyone's business but no one's specific job. So it's not, what this work found is that no one or no professional group is routinely having that conversation with their patients, and we'll see a bit of that data. And there were some suggestions that there really needs to be changes to a model of care to incorporate in a protected space for these kinds of conversations to be had, because they're not happening routinely, simultaneously. So going back to the patient factors, largely patients were unaware of the link, and 8 clinicians, so again just under a third, reported that patients ask about alcohol in relation to their cancer. So more than 2/3 are saying this is never raised by the patients. And 4 of the oncologists said that their patients are certainly unaware, and we've got a quote by one of the oncologists here. Patients don't commonly link alcohol with cancer risk, unlike for smoking and lung cancer, which is more well known. The most common perception regarding alcohol is that it causes accidents. I think that speaks for itself. With regards to patients' factors, so when it was raised, it was about, can I drink alcohol? Can I drink alcohol and have radiotherapy? And dietitians are nodding. Can I drink and have radiation therapy at the same time? Which is fascinating for those that know the logistics of how that may or may not work. And so it was really about that drug interaction mainly. Those key messages weren't getting through. And we all know what an opportunity it is to deliver lifestyle messages, given that a cancer diagnosis is such a powerful motivator, often, not always, to adopt different lifestyle behaviours. And there's some more quotes there that the clinicians were saying they hear from their patients. Has the alcohol caused my cancer, and does drinking too much? So they came up rarely, but when they did come up, that's what was being asked. I haven't presented all the data here because there's a lot to say in a short amount of time, but some of what else came up, and it's in the paper, you can read it, is clinicians' own views and own behaviours about drinking alcohol. And I think the dilemma is, you know, 60 mils a day is tiny. Are we doing that? Do we expect our patients to do that? If you're a clinician that abstains from alcohol, then it might seem a reasonable thing to expect others to. If you don't, are you holding back because you just assume that's not realistic? So I think these are all common clinical dilemmas, but the issue or the question today is how much of those factors should come into play, and how much should we be being led by what the evidence says and what actually is happening in practice, and how do we make sure our patients get consistent messages? The standard drink framework is really unhelpful for patients, is what clinicians were saying. And we need some diagrams. You're saying we need a simple one-pager. We don't want to create a booklet and just give it a patient to take away and not be able to interpret that. but those specific quantities are really unnecessarily specific, and they're quite time consuming to go through. Coming back to the too generous, and so what we found in the studies is that some clinicians were making up is too loose, but I guess electing to use their own descriptions about quantities of alcohol based on the evidence that they were aware of, but in much more practical terms. So saying you should only be having a maximum of half a bottle of wine a week. So we think about the 60 mils a day business, that equates to half a bottle of wine as a maximum, rather than showing them all these pictures or saying what the upper current limits are. Interestingly, clinicians, and they're quite honest about saying, well, look, I don't treat all my patients the same, because some have a really poor prognosis, and I wouldn't bother going down this line of advice, especially if there's other priorities. Whereas if someone was overweight or postmenopausal, I know that their risk is greater with their alcohol intake, and so I'd be more likely to raise a conversation in that context. When Panthera presented this slide in COSA last year, she had a really neat diagram that sort of looked like that. Whose job is it? You know, all the arrows were pointing to everyone else. So the dietitian thinks it's the doctors say it's the nurses say it's the doctors. Everyone says that the GPs aren't asked. And I think we see this with a lot of clinical issues. So there was really wide difference in opinion. I don't know, it's a small group here, but it was a small test case about, well, whose job is it to say this? And our risk is if everyone thinks it's someone else's and no one actually says it. And there's two quotes there. So one of the dietitians said general practitioners should be responsible for assessing patient alcohol intake and providing advice, which is reasonable. And the oncologist said that they didn't mind providing alcohol advice, but believed that this task should ideally fall to the dietitians, which might also be reasonable, only if the dietitian expects that that's their role to do. Some clinicians said that they actually didn't give alcohol advice because they presumed someone else was going to do it, also a problem. And this is a nurse saying that she never initiates discussions about alcohol with patients because it's considered medical advice and therefore considered the responsibility of oncologists or GPs. And again, I use these quotes not to judge, but to say that we really are underpinned by some clinical assumptions without always checking them out. And what that means is that patients don't necessarily get advice and certainly not consistent advice. In regards to, I've got a bit more time, but I'll just go back to talk a bit more about the alcohol guidelines that are being reviewed, because at the moment they're our key public health recommendations, even though in a clinical setting you might suggest alternatives to that. They're currently being reviewed, and the process that the NHMRC are using that is a 9-step process that they use to standard guideline development. And so the process, or the place that it's up to in the process at the moment, is that in January this year they closed off a call for evidence. So anyone was able to write to the NHMRC and say, here's a list of papers, or here's the EndNote library of all the papers that you should be reviewing in making your assessment of what the guideline should be. The Cancer Council contributed to that. There's clearly been some papers, including this one, the Qualitative study that has been published after that date. And so one of the methods that is certainly open for people to using, and I wrote to Professor Kate Conograve, who is the Professor of Addiction Medicine at University of Sydney and is chairing up this alcohol review group at NHMRC, is to say, hey, we've got some new evidence. Here it is, here's the paper, didn't fit into your process earlier in the year, but also made a call in that to consider subgroups specifically. So this one-size-fits-all business might not be an appropriate approach to take. However, recognising that it's really important to get a balance right between conforming to the evidence, and when there's strong evidence, and I'm not sure we've got strong evidence, but also giving clinicians practical tools that don't mean having to remember a whole lot of sub-level recommendations if actually the evidence isn't there to support that. So that letter was acknowledged. And then the guideline, or the timeline rather, is that The evidence is currently being evaluated. There'll be revised guidelines drafted in the first half of next year, and a public consultation will open for those in the third quarter of 2018, so about another year from now. And so I'd encourage groups to input into that, and then the final guidelines are due to be issued in early 2019. In terms of our implications for practice, I think I've said most of that, but it's evident to say that we've got opportunities to improve clarity and promotion of national alcohol guidelines to better support clinicians in the provision of productive alcohol advice. And that we've certainly got opportunities to improve patient awareness of the link between alcohol and cancer, and to suggest improvements to patient education resources. And there's some work going on at Cancer Council to do that with the generous input of some of the dietitians here at Peter Mac. Where in the model of care do we provide standardised provision of alcohol advice? So again, just to cap off on some of the work being done at Cancer Council, we don't want to keep reinventing the wheel, but we do have an honours student with us at the moment who's looked at what tools do exist for patients to self-assess perhaps how much they're drinking, or quick tools to use in clinic. So some of that will come out, that systematic review is being written up. There's a group called, or a portal called Hello Sunday Morning. I'm not sure if any of you have seen that. But as the name suggests, it's a bit of a reality check around how much people are drinking or how they're feeling on a Sunday. And that group says that they're committed to helping people develop healthier relationships with alcohol. So there's tips and tools around like that. Again, eliciting expert opinion to identify the best frameworks and features for inclusion in new tools to assist clinicians. So really getting clinician input, and then perhaps piloting something with patients and getting feedback on how helpful or not that is. And I know that sounds like it's a pretty low base, but I think what you've heard today is we're not consistently giving that advice, so it's probably worth checking out how best to deliver it. And the systematic review will certainly help inform that. In the Behavioural Research Centre at Cancer Council, and they're the team, you'll remember, who have had such successes with plain packaging and tobacco control. And I think the view is, well, why don't we do this for alcohol? Or does more need to be done in terms of raising awareness of the public harms of excessive alcohol intake? So they're working on that, and specifically looking at what harms are most conducive to alcohol labelling and packaging, and testing the effectiveness of television advertisements for increasing awareness of low-risk drinking guidelines. I think this is my last slide. So it's conclusions, but also some key messages. We have an opportunity as clinicians and the public health workforce to make that link for people. We think about years gone by and the situation with exercise and cancer outcomes. It's reminiscent of this. I think we know it, or we're starting to know it. Our patients don't know it. There's more to be done. And we need to make those links clearer. We need to take responsibility for that. I'll get to the drinks industry in a minute, because I want to flip back to a slide and some of the commentary that came out in the media. But certainly there's a view that the drinks industry don't make our job as clinicians easy, because consumer confusion can be seen as benefiting the beverages industry. Frameworks for assessing and advising alcohol currently lack practical and clinical utility, so how do we work together to improve that? New models of survivorship care are being explored in Victoria. We know that through all sorts of mechanisms like survivorship care plans. I think Concord Hospital in Sydney has a survivorship clinic. There'll be other models of that. But what clinicians are saying here is that there's a space that we want to feel confident that a patient will get all the lifestyle messages at a timely manner through clinicians, and we'll know that we're either part of it or someone else is doing it, and we'll feel confident about that. And obviously we need further research to inform clinical practice and policy development. The other two things that I don't have there is one is reinforcement, and I think now you've had the opportunity to hear about the impact of the work that was done last year, and that impact will hopefully continue. is to say that we should encourage scholarly selective projects to occur outside of the clinical setting. One of the students that ultimately opted not to participate in this project was told that her stethoscope would get rusty if she came to a non-clinical environment to do the work. So hopefully I've made that argument that actually there's some outputs outside of that space, and I think I'm allowed to say that because I'm a clinician by trade. And I'm just going back to one of the media quotes in the earlier slide, and you probably won't be able to read that, it's quite small, but it starts off by saying, Alcohol Beverages Australia Executive Director Fergus Taylor said the industry supported consistent advice on alcohol consumption, but it should be based on more credible and accurate evidence. And the study scope is extremely limited and its results inconclusive. Its authors notably acknowledged methodological problems regarding the results and interpretation, he said. So that's no surprise to me, we do. But it's interesting the take that goes on, and I think partly is why the media story was so prolific, because there was that debate or that controversy there. I'm going to finish there. There's a slide that has references on it, but I'm happy to take questions, or would be very privileged to hear some internal discussion going on, and for those online I'll be able to repeat any questions that do come up. Thank you.